Dr. Derek Lee. My pleasure to welcome Dr. Per Trobisch, who is the Chief of Spine Surgery at EFIL Clinics in Brigida in Semmerath, Germany. Today, we're going to talk about the latest findings on a new technique, well, very new technique, which is basically a hybrid VBT with apical or segmental fusion. Welcome, Dr. Trobisch.
Hi, Derek. Thanks for having me again. You did a wonderful job explaining to all patients about VBT and the whole procedure. And it's a few years now, so there are developments. It's an evolving technique, and happy to share our new findings. So if you want, it's a little bit hard to explain. So I prepared a few slides with a few images. So it makes it a little bit easier for everyone to understand this technique. And after that, we can discuss a few questions if you want to. How does that sound?
Sounds perfect.
Okay, so just as a little bit of an introduction, as you know from my other talk, from my other interview with you, I always focus on the lumbar curves. These are my go-to curves. And I believe it's really worth doing VBT for these curves because this is where the flexibility happens. And then we switched to a two-chord technique. Maybe you know that already a few years ago. And it got much better. And we recently published our data. And the data is not that bad. So we were able to have a 50% correction after 2 years, which is comparable to fusion for lumbar curves. I'm not talking about thoracic curves. The problem is that we see many breakages. Actually, 90% of breakage, 90% of patients had at least one level with a tether, with a broken tether. So now it doesn't mean that a broken tether is a failure, and this is a good example. So here we have a patient with a 41-degree curve, not a huge curve, but it's a lumbar curve. And then on the right side, or actually in the middle, we see one early X-ray here. And on the right side, we see a 2-year X-ray. The patient is skeletally mature. As you can see here, the screws are parallel to each other. This is the level L1, 2. And here they're a little bit more open to this side. Can you see that with the white arrow? And it's an indirect sign for a broken tether. We can't see the tether yet, but it's an indirect sign. So despite that broken tether, we still have less than 10 degrees. So this is, for me, it's a successful VBT for a lumbar curve despite a broken tether. But still, not everyone is that perfect. And it's a parameter, or it's something that we like to control better. And as you know, I'm always focusing on understanding the whole situation and not just observing it. So I had the chance to work with a great engineering team of the Aachen University in Germany, which is considered one of the best technical universities. And we do biomechanical testing, and we look for computer modeling. And we found that the L1-2 disc, so the first lumbar disc, is often a problem. This is usually the middle of the curve, and it requires a lot of tension. And just to give you a little bit more insight. So imagine this is a lumbar curve. So maybe we have L3 to 1. Let's say we have T11 to L3. This is a lumbar curve. Let's say it's a 50-degree curve and the patient is immature and all these parameters fit, and we could get bending X-rays. So now we have a bending X-ray, and the spine is much straighter, right? So maybe, let's say it bends down to 20 degrees. And if you remember, many years ago, one of our criteria was, for example, RISA 0 bending down to less than 30 degrees or so. But we only looked at the full bending correction. And even if this is a 10-degree bending on maximal correction, what you may be able to see is that the L1-2 level here, if we call this L2, is not getting parallel. So what does that mean? It means I can achieve this correction with tethering, but on this level, to get this parallel, I have to tension the tether like crazy. So much force. And this puts so much tension on the tether that it's more likely to break. This is what we found in our computer modeling and the biomechanical data. So I have to take stress from this level. And to be true, this disc, the soft tissue between the bones, if this does not get parallel, even if the patient is on anesthesia, on the side, lying on the table, on the OR table in a side position, then it's probably not healthy anymore. So So maybe it's okay to sacrifice it. So what we do is we take out the disc and put a block in here, as you can see here. This is what we call the apical fusion. We call this a cage. It looks like a little Lego brick or so. So it's just a flat piece of plastic. And it opens up by pushing it in. It opens up the opposite side of the curve here. Here on the bending X-ray and even on the over table, it does not open up, but here it opens up. It gives us much more possibilities. And we checked it, and we just published our early results. And after 1 year, we found that the breakage rate is 90% reduced, which is great. And we're not talking about the fused level. Initially, my intention was, if it breaks at the fused level, at least it's fused, so we don't see a collapse of the curve. So the curve will not come back because it's fused. But what we found in our data is that the levels next to the fusion, they are also reduced by, the breakage rate is reduced next to the fusion. So why is that? And again, we went back to the lab and did some testing. This is unpublished data, and I don't want to show you all, don't want to go into detail because it's a little bit more difficult to read, but I can tell you, and let me go back one slide, by putting in this cage here at the unhealthy disc, I don't have to tension the rest of the levels so hard anymore. So it takes off tension of the tether, and this is what we can confirm in our testing. And this is probably the reason why we see a significant drop of breakage rate. And here's a clinical example. We have a 45-degree curve here, and this is the bending X-ray. And the full curve looks nice. It's below 20 degrees, but the L1-2 level here, it still has 16 degrees. And the patient is even a little bit more mature. So I'm not expecting a lot of growth modulation. So what I do here is I put in the cage, and the cage is not visible on X-ray. You only see these very small white lines. And these show us where the cage sits. And then we see a balance. The red line is the balance. Before surgery, it's way off midline. Here's the midline, the middle of the pelvis. And after surgery, it's perfectly balanced. And here's magnification. As you can see, the L1-2 level, there sits a cage in between here. It opened up this side here. So this one cannot break because it's fused. But because it's fused here, I need less tension here and less tension here. And then breakage rate decreased. And here's another one. And I'm almost done with the introduction. Big curve, as you can see here, even a double-shaped curve. Very, very straight on bending X-rays. Super straight. But just looking at the pre-op X-ray, it's too much rotation for me and too much tilt in that disc. So we decided to put a cage. And here's an intraoperative view of the disc. This is the line for the disc. So here's the outside of the curve. Here's the inside of the curve. And even in anesthesia, the patient still has a 5-degree wedge. I hope you can see that. And after putting in that cage and sliding it a little bit across midline, I can correct this level from 5 degrees to -8 degrees. So it gives me much more power to control the apex of the curve. This is after correction, and this is her after 1 year. So we have only a lumbar tether, 1-level fusion instead of a 12-level fusion, which would be the standard for this patient. 1-level fusion, 5-level tether also, and this is where we are so far are very happy with. And let's talk about this.
Absolutely. So when you use the apical fusion, right, you're still using double tethers to hold that on the tethered side, correct?
Yes, correct. I still believe that because we're not fusing the whole curve, I still believe the double tether is a little bit stronger, but also gives better correction for rotation. Only for lumbar curves. In thoracic curves, I usually don't do double tethers.
Okay, it makes sense. Also, since the apical segment is fused and it reduces the tether tension at those locations, when you do have tether ruptures, where do they generally happen? Further along the distal areas from the apex?
Yeah, so a very good question. And we checked all our ruptures and breakages, and it seems like they break from the outside of an instrumentation to the inside. So let's say you have a tether from T10 going down to L3. L2-3 would be the first one. Maybe T10-11 because it's the upper part. but they go from outside to inside.
We talked before in terms of when the tether ruptures, it happens in between the screws. Are you still noticing that as opposed to breakage at the screw?
Right. As you know, this is a very important question. And a while ago, many surgeons believed that it's the screw tether interface because there's some rubbing and this is where it breaks. And then there was a computer modeling study, not a biomechanical study, but not a real study, but a computer modeling study that found that this may be a risk factor. So we have done a few hundred cases now, and of course I had to revise a few cases. And when we analyzed these tether breakages, more than 2/3 break at the disc level. So this is where the most flexibility is, not close to the screw, but a few still break close to the screw. So it's the majority breaks at the flexibility level, but not all of them.
What are the deciding factors between using one cage as opposed to having to add a second cage, or do you actually, is there a max amount of cages you would use for this particular procedure?
There is not. So you could use a cage for every level. What we do is that we check for healthy disc, if you can say so. So for bending X-rays, we check for maturity, and for very severely wedged disc, I like to use a cage, not for everyone. And we still don't have a very clear defined algorithm, but more likely those patients who have a wedged disc who are a little bit more mature, they usually get a cage. I have done up to 2 cages in a primary surgery, but I have done 3 cages in a revision surgery. So I have not done more than 3, but there are, from the degenerative surgery, we know that you can do 5 or 6 cages if you want to.
Mm-hmm. And you can still maintain integrity using the double tethers.
Yeah, but if you use 5 cages, then it's probably a fusion of the full construct. Then you may not need a tether anymore, just put a metal rod.
For sure. Now, you touched on basically not just the Cobb angle of the curve, but significant rotation as well. And with the use of the cage, you find you have much more control over rotation.
Yeah, so rotation is hard to measure actually, especially in the lumbar spine where we don't use a scoliometer, where it's not as reliable. So it's just a feeling on X-ray. But I think these are, how you call it, reciprocal changes. So if you correct one plane, the others will automatically also correct. So we see a better control of the apex with the cage. And I can't say yet that we see better correction. We haven't measured that. It's really hard to measure. I don't know the answer.
Okay. We talked in previous interviews in terms of, at the beginning of VBT, how, very excited about the process, then parameters were kind of shifting all over the place, right? And with tether ruptures for certain curves, like thoracic curves, and the adoption of double tethers, and now we're going to apical fusion. What's your overall feeling in terms of this particular surgery?
We all of us are getting better. I believe in the future we will have many parameters like segmental parameters. It will be very complex algorithm. So at the beginning we said it's a young kid, so 50-degree curve bends down to less than 30, RISA 0. That's it. I believe in the future we will have calculations for growth modulation. We will look at flexibility at each segmental level, and then thoracic versus lumbar. We will look at different tether constructs, and then we come out with a final plan that may be an apical fusion, that may be a hybrid with a thoracic fusion lumbar tether. Maybe some patients qualify for just a single tether, no fusion, no release, nothing. So, but it will be very complex algorithm. The more tools we have, the better, I believe. This is one more tool. Yeah.
Okay. Of course, I always get asked questions for more from patients with mature or adult spines. Is this a surgery that's available to them, do you think?
You know, it's difficult to answer. So we don't have any data yet. So I cannot recommend this surgery for adults or fully mature patients. We know that fusion can easily be done for adults, and I personally believe that this could be a solution for young adults who are skeletally mature but have, you know, a flexible curve still. So now the other thing is, you know, how you say, it's, you know, certifications and approval, and some implants are not approved for adults. Sometimes the insurance companies will not allow it, and medical insurances will not approve it. So this is a complete different part. And before we have any data, we cannot go to medical insurance companies, for example, or other authorities and ask for approval. So it will take some time, but I believe this combination of partially fusing a few levels and maybe non-fusion for the other levels could have some potential.
Have you found that your colleagues are more open or kind of like this approach by using the apical fusion and the cages, as opposed to using just tethers alone for the lumbar spine?
So when I go to these expert meetings, I have the feeling that the past years there's a trend to lumbar curves, VBT for lumbar curves, and I have the feeling that as surgeons get more experienced, more and more surgeons are using double tethers. So I just feel that single tether lumbar surgery is getting very rare. It's not completely gone. Regarding your question, I know that we had many surgeons are not very into learning more about disc releases. And I see that these surgeons are much more into this option of completely fusing the apex instead of doing some disc releases. So orthopedic surgeons don't like to cut into a pediatric disc because they believe, and I agree, they believe that it can cause some problems in the future. But orthopedic surgeons are totally fine with fusing a disc because they believe, well, we know that fusion actually has a good outcome. And if you can have a patient where you only fuse one level instead of 10 levels, and that's probably maybe a good idea. Yeah.
Well, and it does make sense that if you could put a cage in to square off the disc, so it's parallel, it is going to reduce the tension on the tether for sure. So even with, well, let's go into a little bit more into that as well. So let's say for this particular construct with the apical fusion with VBT, if there is a tether rupture, you know, eventually, maybe in 3 years, 4 years, et cetera, at the fused level, do you feel that there's enough support, that it's been in that alignment for long enough that it will hold after a tether rupture?
So that's a good point, and it's something that people have to understand. So if the fusion is successful, then the curve will very likely stay there. So the curve will, at least at the fused level, will not come back because it's fused. Most of the curve, usually more than 50%, is located at the apex anyway. So maybe we have at least 50% correction forever. But there is a risk that the fusion will not be successful. And this is something where we carefully look at, because fusion often uses a cage and a metal rod. So here we only use a cage. So now we know that it's called standalone fusion, just a cage. We know that it can work, but there's a risk that we create what's called a non-fusion. So that means that the cage does not grow into the bone. We also know that the pediatric population, they fuse extremely well. You don't need any artificial bone graft or so. They usually fuse very well. So we carefully look at that. And so far, we have not seen any non-fusion. We have not seen any loose cage or migration and motion of the cage. And if a cage does not get loose in the first year after surgery in a pediatric population, it's probably safe to say it's completely fused. So I would say if you have a stable construct after a year, it should stay stable. So in the long term, even in long term, 3, 4, 5 years, which we don't have the data yet, but it should be very safe.
Have colleagues ever asked you why don't you just do a traditional fusion with rods at one level, and I don't know, tether around that, or is that another option as well?
Yes, it could be, but I don't think I have the tools for that. So I still do the double tether. So I need the screws for my tethers. So if you have some kind of a transition implant where you have a rod in the middle and a tether at the end, that could work, but I don't have that tool yet. So I'm also very in close contact with industry and always trying to tell them the trends, but that also takes time.
Of course. Another question I had was with respect to flexibility. Do you still need quite a bit of flexibility of the spine in order to use this particular procedure? Does the lumbar curve have to correct down, to a certain degrees to use apical fusion?
No. So when you take out the disc, you create so much flexibility. You can basically do that for any kind of curve.
Do you find that, with all the biomechanical studies you're doing and with the data you're seeing now, I know it's only for a small cohort, do you feel fairly confident in this particular procedure compared to other variations of VBT for lumbar spine?
So it will not replace, and we're past the time where we have different techniques and different surgeons believe their technique is better than the other. So I think this one widens the indication for tethering, especially if you have a very rigid apex. So I still do double tether without fusion, for example, for lumbar curves. I still do single tethers, but I also use the hybrid technique now that other surgeons recommended with thoracic fusion, lumbar tether. It depends on the curve type. I use this apical fusion. So I believe it's a good addition to what we have, but it will not be the only thing that we have in the future.
Thanks, Dr. Trobisch, for updating the viewers on what's the most interesting innovation, I think, for coming out of VBT for over the last few years. Very, very interesting. Looking forward to future updates in the future. Thanks so much for your time.
Thank you too, Derek.